All right, everyone, welcome to Every Other Wednesday Echo. Today we have Dr. Charlie Resnikoff as our presenter, and he's always phenomenal, so looking forward to it. He's going to be talking on managing patients in the inpatient setting. And we have some great upcoming speakers as well. Dr. Kurt's going to be doing the next echo on addiction and GLP-1 medications. So there's been a lot of hype about those meds. So I'm really curious to hear his presentation. And we have Cole Perringer coming up, as well as Delisha Carpenter. And then if you want to check out other echo platforms, feel free to click the links at the bottom of the page and check those out as well. And remember, even though you're probably eating lunch, we still love to see you in your Hollywood squares. We don't mind that you're eating. And just turn on your camera. We love to interact with you. And there is free CME with these sessions if attended live. And remember to fill out what Katie sends following these presentations in order to claim your CME. Just a reminder, if you need any technical assistance or you just want an ear to run by a situation, you can always give me a call or Dr. Kurt or anyone else on our ECHO team if we can help you navigate through any scenarios or guide you to resources for policy, protocol, anything of that nature. Don't reinvent the wheel. Check with us first. Next slide. And the Center for Opioid Resources and Education through Stratus Health is a great place to check out the manual that was written on this programming and just kind of look through any sample policies and protocols that are helpful. With that, we will turn it over to Dr. Charlie, and we're so happy and thankful that you were able to join us today.
Okay, thanks for having me. Okay, I'm now going to officially close my EHR down so I won't be clicking refresh on anything. Okay, so I'm going to talk about a topic that these slides were actually, I just presented on this. So you'll see these slides are from the Mayo Clinic conference, whatever. Unless they might have gotten reformatted, which is cool with me too. But I just recently presented on this and this opportunity opened up and Kurt, Aaron, and I thought that maybe this would be a good topic to talk about. This, for many of you, I suspect will be a little basic, but for some of you, it'll be new information. And also, I think there will be ample opportunity to discuss and talk about more complex situations. So I cover the sort of fundamentals of treating opioid use disorder in inpatients, but I am invite challenging cases and we can have a discussion. I think there should be time for that. So Katie's going to be my driver. I'm riding in the front seat, the passenger side, and Katie's driving. I don't have any disclosures. I'm going to talk about a few off-label things, but I'll mention it, and it's all evidence-based. Next slide. So she did reformat that. Thank you so much, Katie. You're like on top of things. I know that you always are on top of things, but extra thankful for that. So let me just make sure. Okay, it's got a page. Okay, so the learning objectives, opioid use disorder, what is it? You guys probably know all about that. Initiating OUD, I am sure you've heard a lot about that. Managing buprenorphine in hospitalized patients who required opioid analgesia. And then managing methadone in patients with OUD who are hospitalized. So those are going to be some topics that we'll talk about. Next slide. And I'm going to do this, well, you all know this. This is more for them. I don't use abuse, dependence, polysubstance, or addict. I use substance use disorder, and I list it based on the substance. So I'm just going to use that nomenclature. Next slide. So these are case-based, and there'll be opportunities to answer the question, and then we can discuss why I chose the answer that I had. And these are all like very bread and butter hospital medicine cases. We could talk about it, and you could challenge me or come up with a more complex case if you wish. This is a 30-year-old woman who's admitted for a non-fatal opioid overdose. She's encephalopathic, and she has an infection in her skin, her left antecubital fossa, where she injects. So what happened was 911 was called for an opioid overdose. They gave her naloxone. She responded, and then she got agitated. And then they had to give her a bunch of antipsychotics to calm her down. And then she got over sedated. So then they brought her to the emergency department, and other than being sedated, she was stable. They started antibiotics for her infection in her arm, a cellulitis where she injects, and they admitted her to the medical service, and that's why you or I am seeing her. So the next morning, she's looking pretty good. She woke up and she's, she's talking and looking you in the eye. She's making sense, and she says, "Hey, get me out of here. Give me oral antibiotics for my cellulitis, and I want to go. Get me out of here." Happens all the time. Next slide. Or yeah, so is this where can we do the an audience response thing, Katie? Did you set that up? Perfect. So what is the best intervention for this patient at this time? Place a legal hold and begin proceeding chemical dependency process. Chemical dependency commitment process, initiate buprenorphine at normal doses for opioid use disorder, establish which substance use disorder she has, or discharge with naloxone and a referral to addiction treatment. So what would you do? And once we feel like, Katie, you're in charge, once we feel like we have enough answers, we can we can reveal the answers. Okay, awesome. Nobody's putting this person on hold. I like that. And we can talk about holds, which is like an advanced, in my opinion, inpatient topic. But there's a little bit of a split. And I agree with the majority of you who says establish which substance use disorder she has. So next slide. So this case was meant to illustrate fentanyl adulteration in methamphetamines. So she doesn't even use opioids normally. She doesn't know she's using opioids. She's trying to use meth, and she got poisoned with fentanyl without even realizing she was using fentanyl. That person does not need to be on MOUD. She does not need to be on methadone or buprenorphine, probably shouldn't be. So you do, before you were to start buprenorphine or methadone, you need to have this conversation. And you all know there's 11 criteria for OUD, and I can't even remember them all on any given day. So I have to look them up often. So you can look them up, but you need at least 4 under normal circumstances, 4 criteria to start buprenorphine or methadone. And I'll give you a shortcut if you're taking care of someone who's hospitalized in a little bit. So, but those are the criteria. There's 11. You can look them up, the DSM-5 OUD criteria. Next slide. The issue, of course, is that 10 to 15% of cocaine and methamphetamine is adulterated. There's a lot of buzz about marijuana being adulterated, but it's not been substantiated. There's a lot of concern that marijuana is adulterated with fentanyl, but it's almost never been proven. But the cocaine and methamphetamine, that's a real thing. Also, anyone using Xanax or street pills, you assume there's fentanyl in there. So something like 50% of the illicit street pills are counterfeit with fentanyl in them. So fentanyl is out there, and there's a lot of accidental fentanyl poisonings in people who do not have opioid use disorder. Next slide. So what would I do? In such an instance, I would avoid MOUD. I would not give buprenorphine or methadone right now to someone who does not have OUD. If they're just stimulant users, I would educate them about the fentanyl drug supply, prescribe naloxone. In Minnesota, fentanyl test strips are legal, so I would do that. I would use naltrexone off-label for stimulant cravings. That's off-label. There's some evidence to support that naltrexone lowers stimulant cravings. And then also, they're protected from fentanyl poisoning. And so I will even sometimes tell them, take this every day for stimulant cravings, or since some stimulant users don't have really like a normal daily cycle, they don't like wake up with the sunrise and go to bed with the sunset. They don't, they're like they're like up all night and they sleep at weird times. Sometimes I'll even say, hey, if you're going to use methamphetamines, maybe take one of these naltrexone first. Number one, it'll protect you against fentanyl. Number two, it might lower your methamphetamine cravings. So I'll sometimes coach them on that. If they haven't taken the naltrexone every day, just take it before you use meth, and for the next 24 hours, you should be protected from fentanyl poisoning and lower your stimulant cravings. Obviously, syringe services and referral to treatment are really important. So naloxone and referral to treatment, the final answer that some of you guessed, is not bad. It's not like a wrong answer. I would just try to establish methamphetamine use disorder, which was the case in this patient, in addition to doing those things. Next slide. So a couple tips. One is that many patients without opioid use disorder have opioid overdoses due to fentanyl adulteration in stimulants. And Xanax, by the way. So in the hospital, you see those cases all the time, and you don't want to just put everyone on methadone or buprenorphine. You want to see if they really have OUD. Next slide. And this is my tip for hospital clinicians, and that is if you're in the hospital and someone uses opioids or fentanyl every day, they're tolerant, and they've had withdrawal in the past, and they're in the hospital for any medical consequence, overdose, infection, whatever, they have OUD. And that's like those four things are really common in opioid use disorder. I use fentanyl daily. I've gotten tolerance to fentanyl. If I stop, I go through withdrawal. And here I am in the hospital with a medical complication of my fentanyl use. That's all you need. You don't need to do the 11 criteria because each of those is a criteria. 4 criteria is moderate opioid use disorder. Boom, buprenorphine right there. But if they say, no, I don't use fentanyl. I never use fentanyl. I don't like fentanyl. That was it. There was fentanyl in my drugs. I wasn't trying to use it. I've never had opioid withdrawal before, and I don't have tolerance because I don't use it. Then that person does not have opioid use disorder. Okay, next slide. So, and a lot of, this slide's out of place. We're going to come to this later. That should be later. I made a incorrect edit to my slide. So we'll go to the next slide, and I'll remember to come back to that question. So, and then we'll come back to this. I'm sorry. I put these 2 slides. I inserted these 2 slides. So next slide. I inserted those 2 slides in the wrong place, but we'll come back to that. So case 2, opioid use and diabetes. So this is a 52-year-old man with type 2 diabetes who presents to the hospital with hyperglycemia related to medication non-adherence. In the hospital, we start him on insulin and IV fluids, and we correct his electrolytes. We do all the things for his diabetes. And then after 24 hours, he gets restless and anxious. He throws up. He has abdominal pains. He's got dilated pupils. He's got diaphoresis. He tells you that he snorts street blue pills daily for 15 months. During this time, he's had multiple admissions for poor diabetes controls. He's spending more time and money on using blue pills, and his tolerance has increased. He has unsuccessfully tried to quit these blue pills a couple times. Next slide. Those are all criteria for opioid use disorder. So when you hear this, unlike the last case where that person did not have opioid use disorder, this person is like in withdrawal, uses daily, has multiple admissions for poor diabetes control because he's using fentanyl rather than taking care of his diabetes, has spending more and more time, which means which is its own criteria, and money, which probably means his tolerance is going up, and he's unsuccessfully tried to quit. So this guy is like severe opioid use disorder, definitely. So next slide. So now what do we do? What treatment should you offer him for his use with blue pills? 500 micrograms of buprenorphine for opioid use disorder and titrate up. Go ahead with 8/2 milligrams of buprenorphine for opioid use disorder and titrate up. 60 of methadone, or discharge with naloxone and referral to treatment. So what would you do? And I think you all know this, but I'll just say it, that those little blue pills are fentanyl. Like, it's just, they were originally designed to be blue pills to look like Oxy 30s, but they're just fentanyl. So this is someone who's using fentanyl multiple times a day for 15 months with consequences. This is opioid use disorder. If you have doubt, it's always okay to add a drug screen to confirm it's fentanyl. Okay, so I agree with the majority of you. Give 8/2 milligrams of buprenorphine. So that's the answer that I would do. And we're going to talk about some of the other issues. I don't think you need to do the 500 micrograms. We'll talk about why later. That's a low dose induction. And also, methadone of 60 as the first dose is a little aggressive. But even if you wanted to do that, you would need to titrate. And I didn't include titrate in that answer. And you definitely don't want to do 4, which is okay. You want to give them naloxone referral to treatment, but you want to start at MOUD. That's important. And so 2 is the right answer. Next slide. So I've been thinking of this is where I am maybe different from other speakers that you have heard. Maybe I'm not different. I think that addiction experts have harmed their own cause by overcomplicating starting buprenorphine. And every addiction expert has their own protocol. So you'll ask, this person will be like, give a 2 milligram test dose and follow that up with 8. You'll ask that person and they'll be like, give an 8 milligrams and follow it with another 8. And that person, then the next person will give 16 milligrams all at once. And our buprenorphine protocol in the hospital is so hopelessly complex that the general doctors and nurse practitioners are like, what are we doing with this? So it's just complex. And I think we have overcomplicated it. I'm trying to simplify it. First of all, if they are off all their opioids, especially for a day, and their COWS is greater than 8, usually that's 24 hours later, and their COWS is greater than 8, you can just start normal doses of Suboxone, buprenorphine. This person, or in other words, if they are in obvious physical withdrawal, you can just start buprenorphine. And whether you give 8 or 2 and then 8 or 16, it honestly doesn't really matter. I think those are all details. You got to get them to a therapeutic dose. And a therapeutic dose is, in today's day and age, on fentanyl, at least 16 milligrams. And that could be the second day, but pretty quickly you want to get this person up to 16 milligrams. And if they're in full withdrawal, just start with a normal dose. So don't overcomplicate it. If you're pausing and wondering what to do, you're probably spending too much time on it. They're in withdrawal. Just give them some Suboxone. And then you're going to titrate them, and they should follow up soon. I think after discharge, the ideal, so that bridge from discharging from the hospital to their first visit in the clinic is critical. And you want them to have enough medications until the follow-up appointment, but I don't think you want to go 2 weeks, 3 weeks, 4 weeks. I think you want to be less than 2 weeks, ideally 1 week, and that can be a telemedicine visit. That's fine. We can talk about the new updated DEA requirements for telemedicine visits. Those just came out. That's hot off the press. I'm going to mention that in a second. But so moral of the story, if they're in withdrawal, and that's clear, whether that's a COWS score or you're just observing them to be in withdrawal, start them on normal doses, 8 milligrams or more. You're probably getting them up to 16 milligrams or even more than 16 milligrams. And when they're leaving the hospital, you want them ideally to be seen in less than 2 weeks and give them whatever they need to get to that appointment in terms of their buprenorphine refill. The one thing that I would say let's go to the next slide. This is the COWS score. You all know about this. Here's the thing to think about. In the hospital, right now in our hospital, probably in all over the state, we're doing these COWS scores on patients with pneumonia, on patients with diabetic ketoacidosis, on patients in the ICU who are literally intubated, and we're doing COWS score. The COWS scoring mechanism, I'm not sure that it's meant to be used on intubated patients with a pneumonia. So we are sort of using the COWS score in ways that it was not originally intended. So you have to be a little skeptical of the use of the COWS score in a medically sick, hospitalized patients. Nonetheless, if you are observing physical withdrawal, that's the key. If you're observing physical withdrawal, you can start a normal dose of Suboxone, but if they're not in withdrawal yet, you got to be careful. So that's kind of to understand that this COWS score may not apply to someone who's, I mean, maybe you're anxious and you have upset stomach and you have achy bones because you have the flu, and you're sweating because you have the flu, and your heart rate's up because you have the flu. Okay, when you do a COWS score on someone who has the flu in the hospital, you got to be careful about that. Otherwise, you could make the situation worse by causing precipitated withdrawal. So, and then I'll comment about at the end, I'll comment about the telemedicine update if you haven't already heard it. Next slide. So why does this matter so much? I don't need to sell you on this. Buprenorphine lowers mortality for opioid use disorder, and there's a variety of studies looking at hospital discharge, and hospital discharge is really important time to have them on their medicine and bridge them to their outpatient clinic. Next slide. And what dose should we give? I think you've already heard this. Probably separately, but 24 milligrams for fentanyl user is better than 16 milligrams. Back in my day, I mean, back in my crusty old, when I started this, 24 was unusual. Now it's kind of the norm. No surprise. If they're on 24, that is not shocking. Certainly 16 milligrams, do not hesitate. Next slide. This is another piece of data saying 24 milligrams is just better for these fentanyl users. So really no hesitation. If they're telling you they need 24, give them 24. Next slide. It used to not be that way. Hospitalized patients with opioid use disorder, if you are white, you are offered buprenorphine 25% of the time. And if you are non-white, even less. And the bottom line is that everybody, regardless of their race, should be offered this medicine and given this medicine. So nobody is being given the medicine enough, but there are racial disparities to be aware of. So some people are getting even worse. So it's bad and even worse. Those are your options. We need to be giving this out more often. Next slide. So for discharge planning, everyone with opioid use disorder in the hospital should be offered buprenorphine unless they're already on methadone. And then there's not a reason if the patient's telling you they need more than 16 milligrams and they're a fentanyl user, if they're a street fentanyl user, I just wouldn't pause to get them at least up to 16. And you can make that 8 BID. And then when they discharge, they should have enough to reach their outpatient appointment. And that should be within 2 weeks. And give them Narcan. Probably check the PMP. The telemedicine thing, if you haven't heard, the main difference now is audio only telephone visits for Suboxone. You can do it, but only for 6 months. And then you need to see the person in person. So you can do audio only, but you can only do it for 6 months. And then it needs to either be in person or audio visual, either one of those. So it's the telephone only patients. But even those, you have 6 months to get them in either on audio visual or in person. So it's pretty loose, but you should know you can't just do telephone forever. Next slide. Okay, so I thought this was cute. If the COWS is 8, don't wait. Initiate buprenorphine of 8. Whatever. just like a mnemonic for the hospitalists. If they're in withdrawal, you can just start a normal dose. And then whether it's 8 or 16 or whatever, give them a normal dose. Next slide. A stable dose of greater than or equal to 16 milligrams daily for fentanyl users, that's normal. So this is just sort of like they come to the hospital, they have OUD, they've got other problems. Get them going, get them on a proper dose. Next slide. Okay, case 3. So this is a 45-year-old woman with moderate opioid use disorder in remission on buprenorphine. She presents for an acute cholecystitis and choledocholithiasis. Surgery wants to take her gallbladder out on this admission. So surgery's like, we got to take that gallbladder out. The only medication she's on is buprenorphine naloxone, 8/2 milligram films. She takes 1.5 films a day, so that's 12 milligrams of buprenorphine she takes every morning. That's her only med. And the last time she took this was 24 hours ago. Since then, she was admitted to the hospital, and in the hospital, she's been given multiple doses of Dilaudid hydromorphone, 1 milligram IV, and it's working. So she's getting IV Dilaudid, which is helping her gallbladder pain. Next slide. So how would you manage buprenorphine, hydromorphone, and her preoperative planning for the cholecystectomy? Continue the buprenorphine, continue the hydromorphone, proceed with the surgery. Stop the buprenorphine, but continue the hydromorphone, proceed with the surgery. Continue the buprenorphine, but stop the hydromorphone, proceed with the surgery. Or stop the buprenorphine, continue the hydromorphone, and you got to delay the surgery by just 24 hours, and then you can go to surgery. So it's a little wonky, but we see this all the time in the hospital. Someone on Suboxone gets sick, gets in a car accident, whatever, breaks their hip, whatever it is, needs a surgery. So what do we do about that surgery? With the Suboxone and with the IV opioids for pain and with the surgery. So what do we do? Yeah, you're basically got it right. The first answer is the correct answer. A few of you guessed other answers. This has changed over time. It's simple. Now it's like usually the simplest option is what we're doing. You're going to continue the buprenorphine, continue the IV opioids for pain, and just go right on ahead to surgery. And there's a bunch of like nuance, like details that I'll try to get into to like get you to a deeper level because you got this question right mostly. So next slide. Almost always, you just continue the buprenorphine throughout the whole perioperative period. You don't stop it. So here's one of the nuances. If the person had stopped their buprenorphine like a week ago, I would not just restart it. Then you're going to maybe cause precipitated withdrawal. But if there's not a hard like how many days off. But if they took the buprenorphine 48 hours ago, I would just resume it. If they took the buprenorphine 72 hours ago, I'm starting to get nervous. You could probably get away with just resuming it. 72 hours was their last dose of buprenorphine. If it's 4 days ago, 5 days ago, then I'm really getting nervous about just resuming it. Then you got to go into like low dose induction or whatever. But if it's been within the last couple of days, I would just resume it. So that's the first thing. Second thing is this is a debate, but many people are suggesting if they happen to be on high dose buprenorphine, to lower it to 16 milligrams a day and maybe split it up BID or TID. So for this patient, I might do 4 TID rather than 12 QAM. So 4 milligrams 3 times a day rather than 12 all at once in the morning. If you're on 16 milligrams, I might do 8 milligrams BID. That's like style points. You don't have to do that, but a lot of us are doing that. Lower the dose to 16 or less, split it up throughout the day. Those are style points. I think, though, a lot of patients are going to surgery on high-dose buprenorphine and still doing just fine. So if the patient really wants to go to surgery on their 20 milligrams of buprenorphine, I don't think that's off limits. But as like style points, some of us are lowering it to 16 milligrams or even 12 milligrams. And just remember the naloxone in buprenorphine naloxone is basically inert if it's taken as prescribed. It's only there as a tamper-proof formulation. So a lot of people think the naloxone in Suboxone is interfering with Dilaudid. That's not true. Next slide. So the next...
Hey, Charlie.
Yeah.
This is Kurt.
Kurt.
I'm in a car, so I do not have my video on. But
Yeah.
how about this little twist? I'm just wondering what you do with this because we've had some issues where somebody's getting Sublocade and they end up in the hospital and they need surgery and they're 2 days overdue on their Sublocade injection for 3 days or 4 days. Any thoughts on that?
Yeah, I mean, I'm not like an expert on Sublocade pharmacology, but it is super. First of all, I don't have an easy like conversion to like your 33 days from your last Sublocade injection. What is the effective buprenorphine dose in your system? So what I would do is instead of convincing myself that I know what to do, kind of roll up my sleeves and be a clinician and talk to them about how much withdrawal they're experiencing, observe them for withdrawal. That's kind of a sense, and cravings. And that's kind of a sense of how much Sublocade buprenorphine is still in their system. And then give some trial doses of additional opioids to see if they're working or if they're blockaded. But I think so. And then in terms of the surgery,
To continue the Suboxone, which is from on while they're there.
so you're breaking up a little bit, but you could add additional Suboxone to Sublocade if you think the Sublocade's wearing off, and we do that sometimes. But also, the people who've had, what you could do is look at how many Sublocades have you had. Like, if you've had both of your 300 dose Sublocades and you've had 5 injections, you've had 7 total injections and you're getting them every month, you have such a heavy amount of Sublocade in your system that honestly, like the first week that you miss your injection, people might get anxious, but there's so much Sublocade, buprenorphine in their system. I would not, you can always supplement with additional buprenorphine, but even then, you're just like guessing what they could possibly need. So there's a lot of unknowns. There's a lot of unknowns with that, but if they've had multiple doses of Sublocade, it's probably very built up in their system and they can tolerate plus or minus a week. They won't even notice it, honestly. But if they've had maybe only one Sublocade injection, they might feel like it's wearing off at the end of the month, and they may be even physically in withdrawal, and then you need to give them buprenorphine. So I don't think there's a clean answer, but it is be a clinician. Roll up your sleeves, talk to the patient, observe the patient, do some pharmacotherapy trials. And in terms of surgery, I had a person on high dose Sublocade. Like he got 300 Sublocade multiple months in a row, and then he needed to go get a pacemaker placed, and it was fine. So even like extremely high doses of Sublocade, which are effectively like very high dose buprenorphine, and it was a minor procedure, a pacemaker placement, but that's still, they go under your skin and they place this device under your skin on your chest. So it went fine. So but that's anecdotal. So I don't know if I answered your question, but like with the Sublocade, I don't think there's a clear answer. So you just need someone who's comfortable with it and is really comfortable talking to the patient, observing the patient for opioid use disorder. And you might need to just add megadose Dilaudid for pain because the blockade is heavy. Or you might need to add supplemental buprenorphine because the Sublocade's wearing off, or both. So it's very much a clinical decision that we would just like go to the bedside in the hospital, observe, talk to the patient, and try some things, which is an unsatisfying answer, but it's actually really exciting when you're in the moment that you get to be a doctor again. You don't just follow a recipe, or you get to be a nurse practitioner again. You don't just follow a recipe, you observe and treat the patient in front of you rather than like a protocol. So, okay, long-winded answer. I hope that answered your question, Kurt. The Sublocade is complicated, especially for me, because I do it, but I'm not like the world's expert. Like I'm still kind of figuring it out. There's this publication at Mayo that said that buprenorphine doses, the sweet spot to co-manage pain, including surgical pain, and opioid use disorder, is a Suboxone dose between 8 and 16 milligrams a day. So over 16 milligrams a day, they think there's not enough receptor availability and it's outside this. You could still do it, but the sweet spot is 8 to 16 milligrams a day of buprenorphine in the sublingual formulation. What that means for Sublocade, I don't think anyone really knows. I mean, it's probably like the 100 dose of Sublocade. They should be on that, but it's hard to say. So the sweet spot. Next slide. And then you can and should, I think a lot of our inpatient docs struggle with this. You can prescribe opioids in addition to buprenorphine. And what I always say, we got a patient like this right now. I'm in the hospital service right now. The same indications, meaning, and I'll tell this to the patient, we are going to treat you with opioid pain medicines for the same reasons, the same reasons that we would treat anyone else. So if you had a surgery, you're going to need opioids. We'll take care of you. In fact, because of your tolerance and because you're on Suboxone, you might even need a higher dose than the average person. But what we're not going to do, and they love that, right? Like they love that. Oh, you're going to treat me equal except higher dose. But what we're not going to do is give you opioids for reasons that we would not normally give anyone else opioids. And I think they'll accept that. So they say, okay, you're going to treat me the same as anyone else. Alex got a question. Treat you the same as anyone else except higher dose because of your higher dose Dilaudid because of your tolerance, but we're not going to give. But when it's time to stop, we're going to stop. So that's kind of what I tell patients inpatient, and they're and it usually goes really well. Dilaudid is really trendy for this because of its affinity or whatever. So let me look at Alex here. It says. Attendings were adamant that lowering to 12 milligrams was not found to be more helpful for receptor availability than other opioid. Yeah. And it can destabilize patients. Curious your thoughts on this. The furthest they would go is from 24 to 16 in cases of non-response. Yeah. Okay. Yeah. So correct. So like the work to back up about these things, the world of buprenorphine is still full of people's protocols based on imperfect evidence. So if you're looking for the definitive scientific research to establish the correct protocol, you're probably not going to find it either way. So I don't believe in being adamant on any of this stuff because this is like there's a lot of hypothesizing, there's a lot of case studies, there's not a lot of rigorous properly conducted controlled trials on any of this stuff. So I'm not going to be adamant for, and someone who's adamant against, I'm going to be like, okay, so I think we can all be clinicians. I think it's okay to continue above 16. The balance is the farther you decrease the dose, the more you are at risk of creating withdrawal, anxiety, pain. Pain from withdrawal. Anxiety, cravings, relapse, destabilize, leave AMA. So every time, the more you lower the Suboxone dose, the more you're risking that set of things. The more you leave the Suboxone dose at a very high dose, the more you have interference with the opioids. And that is a tension that I think should be individualized and talked through with the patient, and you just do your best. I'm usually not lowering anything down to 12 milligrams for most patients with fentanyl use. There are historic patients out there that didn't use fentanyl and don't have this mega tolerance and have 2 years of abstinence and want to lower down a little farther. I do that all the time, and many of them have navigated the surgery process fine. So I think it's about trade-offs. It's about understanding the trade-offs. It's about talking to the patients. It's about having understanding their risk factors. And it's not as simple as you should lower it to 12 or you shouldn't lower it to 12. It's more like you should understand all the trade-offs, all the limitations of the data, and talk to the patient and make a decision with them and be willing to change. Like if you start one pathway and then they start getting restless and having cravings, go up on the Suboxone. You gotta be willing. Or if you start high and they're not feeling the Dilaudid and they're having a lot of stress because they're in pain, then you need to go down on the Suboxone. So I think it's got to be clinical. Anyways, that's my spiel. I love the question. It's a super important question, and I think one of the themes of my approach to all of this is we don't know enough to be adamant, and there's a lot of addiction docs out there with the protocol that they swear by. I've been doing this long enough that all the protocols get changed. They all get changed. And I don't think we're there on a single protocol, like the one ring to rule them all. In the Lord of the Rings, we don't have our one ring to rule them all. We don't have the single protocol that fits, that's universal. What we have is clinical judgment. Okay, so anyways, you got me on a tirade. I love the question, though.
Charlie, it's really, can you hear me a little better now?
Yeah.
But it's like I always say, it's like there's a lot of right ways to do it. There's just a couple of wrong ways, right? I mean, everybody's got their own thing.
Yeah, that's a great way of saying it. Yeah, and you definitely don't want to aggressively lower Suboxone in someone who's got tentative stability as a high tolerance from fentanyl use. I would be very cautious about lowering the Suboxone aggressively preoperatively in someone in that situation. On the other hand, there are other patients that have greater stability, have less tolerance, and they may actually really want to lower. We used to take people off Suboxone, send them to surgery, and some of them became unstable, but many of them did great. So it's like, yeah, it's very clinical, and I love the way you put it. Sublocade at the time of surgery to decrease the risk of opioid misuse long-term. Interesting concept. And I assume you're talking about in someone who does not have opioid use disorder or someone who does have opioid use disorder. Maybe, Dave, if you could specify, do you mean in someone with OUD or without? I love that we're on tangents. That's exciting for me, but I want to get to the next case.
Be without.
Without. Yeah, I mean, there are...
Would that prevent people from getting hooked on opioids?
Yeah, I mean, the post-operative rate of converting to OUD. So post-op, there's converting to chronic opioid tolerance, and then there's also converting to opioid addiction. The opioid addiction rate post-op are like single-digit percentile, which is a huge adverse effect. But it's not like it's 10% of people coming out of surgery get addicted to opioids. It's like, I think I saw 0.2% coming out of surgery exposed to opioids get addicted, 1 in 500. So I don't think we could give 500 people Sublocade to prevent one addiction. Then there's get tolerant to opioids, become a chronic pain patient, and that's a higher risk. That might be more common, 1 in 50, 1 in something like that. But I think you went to surgery and that's your only risk factor, and you were exposed to opioids in surgery, and then you come out and get addicted to opioids because of that. That's a pretty low risk event. I wouldn't give them Sublocade. I'm editorializing. Nobody knows the answer to that question. A very high risk person, maybe. And also they say this, and then it gets tested and it ends up helping. So you never know. It's an untested question. But I appreciate the question. Okay. So summing up case 3, most patients on buprenorphine should just stay on it through the perioperative period. Next slide. Patients on buprenorphine can receive additional opioids for pain. Remember, higher dose, but not longer duration, and not for unusual indications. And people like Dilaudid. Right now. Next slide. So avoiding precipitated withdrawal. 25-year-old non-binary individual with untreated opioid and methamphetamine use disorders has a soft tissue infection. The patient's medically stable after an IND, a drainage of their abscess, and IV antibiotics. They're requesting opioid analgesics often. There is concern that they're actually using opioids while in the hospital. They're comfortable. Their COWS is 0. The patient states that buprenorphine does not work for them. They had a bad experience after borrowing a film from a friend. Next slide. Okay, what do you do for that person? 500 micrograms of OUD and titrate up. 500 micrograms of buprenorphine for OUD, titrate up. 8/2 milligrams of buprenorphine for OUD. Methadone of 30 for OUD and titrate up. Or treat, they're already on opioid analgesics, treat with opioid analgesics for their surgery. They had a drainage of their abscess, and then they can deal with addiction medicine after discharge. So many hospitalists, I have this, like, the fourth option is always basically discharge with Narcan and referral to treatment. That's all that's happening for so many hospitalists. So it's basically always wrong to just discharge these folks. And the whole point is, like, you all are like very dialed into the importance of this. But when I'm talking to hospitalists, they know they're not supposed to pick option 4, but option 4 is basically always wrong, but yet it happens all the time. So I'm really glad we have like a split here. Some of you want to do the low dose induction. Some of you give the normal. So low dose induction, option 1, 500 micrograms to titrate up, could be good. But in the actual question, the patient's like, I don't want buprenorphine. So you'd have to go back in and explain things and get them to agree to trying a low dose induction. But if they did agree, that would be good. In our institution, we'd be like, we would definitely have that conversation about low dose induction. But just given what's written in the question, methadone is like a correct answer with the assumption that you have a referral to a methadone clinic, and you might not. So exactly what Kathy's saying. If you don't have access, so we at Hennepin have access to methadone post-discharge in the metro area, no problem. So we're definitely going to do methadone. If you don't have access, then you got to go back to the patient and convince them that the best choice for them is going to be a low dose induction. And so that's a resource availability issue. So I totally, I totally get that. Giving them 8 milligrams is going to put them in precipitated withdrawal. We'll talk about that. And then a lot of people in reality choose option 4, but it just sets them up for, they're there because of IV drug use, and you're not helping them change that really long term. You're kind of setting them up for more trouble. Next slide. So we're talking a little bit about low dose induction, and then we're going to talk a little bit about methadone. But first, obviously, precipitated withdrawal. Do not start full dose of buprenorphine in anyone who's just been using opioids. If they've been getting buprenorphine all along, you can continue it, even if they've got opioids added on top of that. But if it's been multiple days since buprenorphine, or they've just not been on buprenorphine, don't start. And I'd say anything more than 1 milligram of buprenorphine could cause precipitated withdrawal. So I would never start anything more than 1 milligram of buprenorphine in a person who's had ongoing opioids. And interestingly, the cows of 8, so if cows of 8 don't wait, initiate 8 of buprenorphine. The cows of 8 came from an emergency department study in Denver, Rigatoni or whatever her name is, amazing. We all sit at the base of the altar of scientific brilliance that she stands on, whatever. Her emergency department study with the cows of 8 had a rate of precipitated withdrawal of 2%. But there was just another study in the hospital medicine context that looked at the cows of 8 and had a rate of precipitated withdrawal of 12%. And I don't know about you, but I've always been nervous about a cows of 8 because a cows of 8 is like pretty mild withdrawal. And I'm like, wow, we're going to give full dose buprenorphine to cows of 8. And then I even had a patient who was cows of 8, and I gave them bup, and they had withdrawal. So anecdotally, I was always skeptical that cows of 8 had a 2% precipitated withdrawal rate. And now we have another study. And this gets to that, don't be too sure of your protocol. Like, don't pound the table and say, I know I'm right. My precipitated withdrawal protocol is right because of this one study in an emergency department context where a cows of 8 had a precipitated withdrawal rate of 2%. Well, whoops, now we have another study and it's 12%. To me, 12% is too high. So to me, now I'm going to go cows of 10. But that's just me. I don't know. That's just me. Okay, so anyways, so if if they're not in withdrawal enough and you're nervous about precipitated withdrawal, you got to do a low dose induction or give them methadone. Next slide. Low dose induction. There are more low dose induction protocols than there are recipes for chili in the state of Texas. Like every addiction clinician has 4 low dose induction protocols, and none of them can agree. And I would love a study where you took a clinical case and asked 10 addiction certified doctors what their low dose protocol would be and look at the agreement, because there's going to be a lot of variation. So I'm not going to pound the table and say my way is the right way. I'm going to step back and give you the big picture. A low dose induction protocol is start at 500 micrograms of buprenorphine or less and build it up to therapeutic doses over 3 to 7 days. And there's a lot of variation within that, but just start low, 500 micrograms or less, and take 3 to 7 days to get it up to normal doses. And that's it. And everyone's got their own personal recipe. Fine. I got my recipes, but I'm not telling you to learn my recipes. I'm telling you to step back and look at the big picture, and that's the big picture. Next slide. So this is just to show you there's these like absurdly complicated recipes that we all have them. We all do this. I do this. We have our elaborate recipes. There's some variety of publications if you want to look up details. Next slide. You can use the Butrans patch. That's so next, Katie, go to the next slide. The Butrans patch is like, it can be handy. So that's great. But again, that's just another protocol. You need your hospital formulary to approve Butrans in the hospital, which we got that done and we use Butrans. It's great. It's expensive, but it can be really useful. Next slide. So my simplified version of buprenorphine is under 500 micrograms is a low dose induction. Start at that dose and build up over 3 to 7 days. Anything over 1 milligram could cause precipitated withdrawal if you start it in someone with ongoing opioid use. 8 to 16 milligrams is the so-called analgesic sweet spot with all the caveats we talked about earlier. And 16 to 24 milligrams is like for fentanyl use. And I think over 24 milligrams is also fair game in some instances for fentanyl use, for opioid use disorder and fentanyl use. And I feel like that's kind of the lay of the land, and everything else is clinical decision making, in my opinion. So everything else is individualizing care within that framework. Next slide. So methadone is changing rapidly. What we used to do is take our outpatient methadone doses and apply them to an inpatient context, and that's crazy. I mean, that's absurd, because in outpatient, we don't see them after their dose to see how sedated they are. They get their dose and they go. So we don't know how sedating it is. We only observe them the next morning, 24 hours later, at the trough. We don't observe them at the peak. And in the hospital, you can observe peak methadone effects. You get their methadone and then you observe them. You're rounding on the patient while the methadone's kicking in. You can see if they're oversedated. So we've absurdly been conservative in inpatient settings. So the outpatient dose used to be 30 milligrams is the maximum initial methadone dose. But even that has been loosened in an outpatient setting. We're going up to 40, sometimes even we get to 50 in the first day. There's regulations affecting that. So the outpatient, we're being more aggressive because fentanyl has such a high tolerance. And in an inpatient, you could really be aggressive. But that said, we don't want to. I have also seen us get super aggressive titrating methadone inpatient, and then a person aspirates because they got oversedated. So we also don't want adverse effects in an inpatient setting. So what we still do is probably 30 but even on the very first day, they can get an extra 10, and then it's 40 tomorrow, and they can get another extra 10, and it's 50 the next day. So we'll get them up to 60, 70, 80 pretty darn quick, like within a week. So within a week, we're often 60, 70, 80, maybe even 90 milligrams within a week, and that is for a high tolerance fentanyl user. But we're starting 30, We're giving additional 10 milligram doses every day, and we're observing clinically. This is what we do, but I'm not pounding the table about this because there's no rigorously studied trial. This is just our clinical practice, and there's lots of practices out there. Observe the patient. That's huge. Next slide. So low dose starts at 500 micrograms and builds gently over days. Next slide. Methadone is still an option for inpatients. You do need an outpatient referral for those, as Kathy Nevins pointed out. Okay, I'm going to see if I can get through the last one. I think I can. It's quick. 60-year-old woman with COPD and OUD, and she's on methadone. She comes to the hospital for a COPD exacerbation. Her COPD exacerbation happened after she got a viral illness. So she got like the flu, and then her COPD exacerbation occurred. This is the first hospitalization in 16 months. She's improving, but she'll be in the hospital for a few more days. She is not normally on oxygen at home, but she needs 2 liters of oxygen in the hospital. Her oxygen saturations are 95%. Her respiratory rate's 18. Her CO2 level, carbon dioxide level, is 52. I'll explain that in a minute if you don't understand what that means. She's not sedated in the hospital. She's been on 115 of methadone daily for 5 years. From everything we can tell, she's doing good on that dose. She doesn't want to change her methadone dose. Next slide. But do you want to change her methadone dose? Here she is with her COPD exacerbation in the hospital on 115 of methadone. Do you leave that 115 the same? Do you lower it to 85? Do you stop the methadone and give her a low-dose buprenorphine induction, or do you stop the methadone and give her a traditional buprenorphine induction? And I realized I put in some like wonky hospital medicine lab tests. I'll try to explain why I added those, but I think you could probably answer the question without those. This is something we see all the time in the hospital. So it's kind of split between the first 2 options. And I agree with the people who mostly think first option's fine. So why is the first option fine? I went out of my way in the description of this case to say, wow, is she stable? She's not on home oxygen. She's not having a bunch of COPD exacerbations like every month. She had it this time, but she just had a virus, and that's the reason. And she's not sedated in the hospital. And another super important thing is her respiratory rate is elevated, and she's dyspneic, meaning she's short of breath. If she was on too much methadone, she would not be short of breath because she's like knocked out on the methadone. She's like nodding off on the methadone. She's not aware that she's having a COPD exacerbation. So that's when it gets dangerous, when her respiratory rate is low, unusually low, considering her COPD exacerbation, or if she's not short of breath. And then her CO2 level would start rising, her oxygen level will start falling, and even though she's not breathing well at all, she's like sleeping. That is life-threatening. You got to stop or lower the methadone. But here she is, totally stable on the methadone for 5 years with normally no breathing issues. She had a virus, so she's having a hard time breathing, but she's still wide awake and experiencing shortness of breath. You should just leave things the same. That said, I think we have this aging group of methadone patients who are getting sick. I think maybe you want to think about buprenorphine at some point is a fair conversation. Maybe you should think about buprenorphine with your COPD. The methadone might catch up with you someday. Today it's not a rush, but someday you might want to think about being on buprenorphine instead. Can we talk about that? I think that's fair. The other thing with point 2, lowering the methadone, if it was in reality, these cases are more confusing. They're sedated, their breathing is funky, maybe they've been using some illicitly, maybe their COPD is more severe than the case that I gave. A lot of times, you're actually worried that the methadone is interacting with the COPD exacerbation, and you have to lower the dose. This case was kind of designed to be perfect, so you leave it the same, but in reality, it's usually not perfect. You're worried about the methadone. And so the most important thing is they get their methadone and go 2 hours after they get their methadone and see how they're doing. And if they're like hypoxic and not breathing and half asleep, you probably have to lower the dose. And 85 would be lowering the dose by 30% is a really good first choice. So next slide. I kind of talked you through the answer to this, but I'll just make sure I didn't miss anything on the next slide. Yeah, you can temporarily hold methadone if people are very sick, or you could lower the methadone by 30 or even 50% if they're like delirious and hypoxic and very sick. You can lower or even stop the methadone dose. It is really important to know that methadone peak effect is 2 hours. So go see them at 2 hours after they get their dose in the hospital and see how they're doing. And that tells you a lot. And methadone withdrawal won't occur for 3 days. So if they're really sick and you don't know what's going on, they're up in the ICU, just hold the methadone for a day. You can always resume it tomorrow. Missing 1 or 2 days is not going to cause them to go into withdrawal. Just resume it when they're in a more stable spot. Or if they never get stable enough to resume the methadone, then you're thinking about a low-dose induction of buprenorphine because that's going to be a little safer for them. And then, yeah, that's about it. So next slide. I think we're basically done. So observe the patient 2 hours post-dose. Next slide. Lowering methadone in hospitalized patients puts them at risk of withdrawal. So you can do it, but just only do it if you need to do it. Next slide. Okay, that's it. I finished like just on time. I can hang out and answer questions. Thanks for everyone's attention and for that. There's some really cool questions.
Yeah, anybody with any thoughts or questions that want to shoot them out there?
I had a question as we're on the topic of methadone, switch to bupe with low dose induction. And I know you're aware of this case I'm talking about. So I have a lady who is on hemodialysis, sits with a creatinine clearance at about 18, who's been on methadone, just 32 milligrams, hasn't been doing well, has had, I think, 2 recent overdoses on mu agonists due to some bilateral femur fractures. So anyway, it comes to me and wants to get on Suboxone. So I got her onto Suboxone. We're now at 8 milligrams by low dose induction. And then she wants to go to Sublocade. And I could be overthinking this, but I just want to be extra sure the methadone has been DC'd long enough with the Suboxone, we're at the 8 milligrams total, has been on board long enough before doing the Sublocade. I'm so paranoid of something sitting around and it bumping a touch of precipitation. So methadone had been out of her system consistently for, I think, 4 to 5 days, but then she took one 32 milligram dose while she was on 8 milligrams of bupe, so it didn't do anything. And then has since been on the Suboxone exclusively 8 milligrams for it'll be 5 days.
I personally think that 5 days of 8 milligrams or more of Suboxone is an adequate test that you're safe to give a Sublocade. Kurt, do you want to weigh in on that?
Yeah, I do the same thing. And plus, she took that methadone, no big deal. Took a little extra dose. She's got enough Suboxone in there. She won't precipitate. I'd give it to her.
Yeah. I mean, I think some of the PAs and stuff want 7 days, whatever. But I honestly, if she tolerates 1 dose of 8 milligrams, I would probably even, I think that's enough of a test that she's going to be okay on the Sublocade, even 1 dose. So that's bold of me, but I think an 8 milligram dose, if she truly took that and did not have precipitated. So what we'll do in the clinic sometimes before giving Sublocade, when we're not sure, we will give them 1 8 milligram dose and observe them in our clinic. And if after 1 8 milligram dose, they're fine, they get the Sublocade. And so we will do a single 8 milligram test dose in our clinic and then proceed to a Sublocade. So I'd go for it. Yeah.
Okay.
Any other questions? I just wanted to emphasize what you had said about protocols and how complicated they can be and how they don't need to be. And, for our hospital, our ED, we just kind of redid them. And there's just 2 choices. One is a low dose one and one is a little bit bigger one. And the variable always is, if there are 24 hours, you can pretty much do whatever you want. It's the people that fall in the middle that are 12 hours or 8 or 9 hours and are acting a lot sicker. I think those are always the ones that you worry a little bit about. But if you give the ED too many choices,
Yeah.
it's like you gotta. So our dosing is 16 just right off, because they wouldn't let me. They wouldn't let me say, if this and this and this, do this, right?
I think we're going to go to just give 16 especially for the fentanyl users. They're going to be on 16 anyways. And then I think it will lessen, it simplifies the protocols. It'll lessen precipitated withdrawal. But that study needs to be done for me to get too fired up about it. But I think just either 500 micrograms or 16 milligrams. I think that'll be the choice in the future, but we'll see.
Yeah, it's like Christmas candy. More is better. So,
yep.
Other questions?
It's like Diet Mountain Dew. More is better.
More is better. But I'm tapering, Charlie. I'm almost off.
You're like someone on benzos. You're like always tapering. You never lower your dose. I got a quick story while you're thinking of questions. I had a patient yesterday tell me he was recovering from a diabetes, and he told me, I believe in the healing power of music. And I said, wow, that's me too. For example, what heals you? Guns N' Roses, Appetite for Destruction.
There you go.
Okay. Well, we all heal differently.
I'd be more of like BTO, maybe.
Yeah. Any other questions?
That was a fabulous talk, Charlie.
Thanks.
Thank you so much. And thanks. Everybody should know that Charlie jumped in at the last moment because Dr. Perringer and I were out at a conference, and our schedules were a little messed up. So I want to thank Charlie again for really jumping in there.
You promised me that maple syrup.
Yes, okay. I will be bringing you syrup. I will be bringing you maple syrup, no doubt. Okay. All right. Well, again, thanks everybody. Next week or 2 weeks from now, I'm doing the talk on GLP-1s and some of what is the latest data, which I'm just going to give you a teaser. There's not much, but it's very interesting. So we'll talk about that in a couple of weeks. So thanks again, Charlie, so much.